Good morning, everyone. Welcome to the Health Literacy Training Session. I'm Dr. Carolyn Custer, and this is Maya Campbell, and we'll do introductions in just a few minutes. If you're joining us from the MISHWA website or another online module, we welcome you, and we're going to start by asking you to do our evaluation, pre-session evaluation. So let me just go ahead and get my screen shared here. So again, this is the Wayne County Health Catalyst for COVID Care Health Literacy Training. And this is the pre-session evaluation. What we would like you to do is put your computer on pause and go ahead and either scan this QR code, or you can access the link below the module. And we'll be back when the rest of our guests have joined. So thank you. Okay, so welcome back if you are joining us online. We'll start today with some introductions. I'm Dr. Carolyn Custer. I am doing this work as part of Authority Health and have created this presentation and been working with Miss Maya. So go ahead and introduce.
Hello, my name is Maya Campbell. I am with MISHWA. I'm also a very proud community health worker. Dr. Custer and I are so excited to present this training for you today.
Awesome. Okay, so a quick review of our agenda. We'll go through what is health literacy. We're going to talk about 5 health literacy interventions, take a quick break, and then we'll come back and talk about 2 strategies to overcome vaccine hesitancy specifically. And if we have time, we'll do a case discussion at the end. The learning objectives, describing health literacy as a determinant of health, and then becoming familiar with these strategies. So we want to empower you, give you some tools and skills to improve or increase health literacy in not only your client population, but also in your organization. And then we'll talk about vaccine hesitancy as it relates to COVID. So we'll go ahead and get started today with a brief review of health equity. You can't really talk about health literacy as a topic unless you talk about health equity. Does anyone on the phone or call has seen this box or this image before with the 3 boxes? Does anyone recognize this?
Yes.
Right. So this is our traditional view, right, of talking about equality versus equity. So at the end of the day, we talk about equality. That means that each person gets the same thing. So whether you're male or female, you make the same pay, right? That's equality. Equity is when people get what they need to have the outcome that we want them to have, right? So not everyone has the same needs, and we need to recognize that. So we've been talking about health equity for quite some time. Today, we're going to take it one step farther, and we're going to talk about justice. So a lot of us, we talk about social justice. We're all social justice warriors, I feel like. And what that looks like is, taking it even a step farther. So all 3, as you can see the game because the structural inequity was removed. The cause of that was removed. So how can we get to the systems where we can, put systems back in place so we have social justice for everyone? Social determinants of health. So here you can see these are the things that can impact health that aren't necessarily the clinical care, right? Clinical care is just a small percentage of what impacts a person's health and wellness. Social determinants, all the things that relate to the place where you live, you work, you play. And that really does make a difference. So things like having food, food insecurity, access to education, access to employment opportunities, even access to healthcare. So all of these social determinants play a big role in health outcomes, as health literacy is part of that. So I think I'll turn it over to Maya.
Yes, thank you. So the CDC just defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that are experienced by socially disadvantaged populations. These things do exist because health inequities and factors like social determinants of health and systems that are designed with structural racism. Okay. So health literacy in Wayne County, as we know, or as some of us may know, that Wayne County was historically redline. Is anyone familiar with the term redlining? Does anyone want to unmute and explain or talk about what their definition or what their understanding of redlining is? Has anyone heard that before?
Yes, essentially like realty and realtor covenants to basically keep communities segregated and keep Black people out of predominantly white neighborhoods.
Yes, that's absolutely true. Thank you so much. That's correct. So redlining historically separated people of color from accessing resources like hospitals. It unfortunately is a part of the history of Detroit, and not just hospitals, access to healthcare and education. So thank you again for sharing that. So the next slide we'll talk about health literacy. What is health literacy? What does that mean? What is anyone's definition or understanding of what health literacy is?
We should mention this is an interactive presentation, so we will be looking for some feedback probably quite often. Does anyone have a definition of health literacy?
I think I would just describe it broadly as being able to understand like health information that's trying to be conveyed or communicated to you by a healthcare provider, whatever type of provider or provider setting that is.
Absolutely, absolutely. So thank you. So that's exactly right. Yeah. So, and Dr. Custer, do you want to talk about Healthy People 2030?
Sure, I'll pick up real quick. So like you just said, Lucas, personal health literacy is our own ability to understand our health, the healthcare system. It goes from, getting your prescription filled to insurance, prior auths. I mean, it's all these things that you need to understand to have health and wellness, right? So Healthy People 2030. So this Healthy People comes out every 10 years and they recommend things for the nation. And in 2030, health literacy, increasing health literacy has been a goal in this country, and personal health literacy. But in 2030, they added the organizational health literacy. And I think this is very, very important for us as community health workers and healthcare workers to understand that it's not just on the patient, right? We also have to do things to make sure that access to information is equitable. So it's on us. And we'll talk about both sides of these throughout this lecture. All right, go back to you, Maya.
Thank you so much. So health literacy components that we'll discuss, the skills and knowledge needed to interpret health information, and literacy. So literacy is defined as reading, writing, basic math, speech, and comprehension skills. Numeracy, or the understanding of how to use math in the real world, and being able to apply that to make best decisions. So some factors that impact health literacy: the complexity of the health information. How complicated is it for the patient to understand? Language. Is there a language barrier? Age, state of the patient's health. So are they anxious? Are they sick at the appointment? And also their cultural background. And we'll discuss these factors a little bit more in the training. And also the way that the health information is communicated by the providers. That is another impact on health literacy. And we'll dive deeper into these points later in the training. So this is just a graphic of those individual and systematic or professional factors. So again, literacy skills, knowledge of health, demographics, culture, experience. And then on the professional side, the communication, public health infrastructure, public health workforce, and all these things together make up health literacy.
Okay, so some impacts of health literacy. Why is it important? People with limited health literacy are less likely to, access and obtain preventive services, things like our colon cancer screening, breast cancer screening, et cetera. Less likely to effectively manage chronic disease, right? So you have to have some basic understanding of the health condition to manage your chronic disease. more likely to have poor medication adherence, higher rates of hospitalization, use of ER versus primary care, and even higher mortality rates. One thing that we talk about, and we'll talk about through this session, is reporting a sense of shame about their health literacy. And so later on we'll talk about some red flags, but people may be not asking questions, and we'll talk about the nodders, the yes, because they have this sense of shame. So we need to acknowledge that. And of course, it's associated with higher health costs and expenditures. So on a community, so that's a personal level. On a community level, it can have impacts such as missing opportunities for screenings, vaccines, preventive screenings. I think we do a lot of this in Wayne County. We're pretty good at that. Lack of preparation for emergencies, so severe weather, evacuation, contamination, etc. Public health messaging about food safety. So it's important that we build community capacity as well. So health literacy and literacy, right? So how do they relate? One thing that we have to keep in mind is the average reading level of adults in this country is 8th to 9th grade. However, most of the health education materials that we give out are 10th grade level or higher. So that creates a problem. So what they recommend is using plain language. We'll talk about that in a few minutes, but the best reading material is 5th to 6th grade. So really making sure that you look at what you're handing out to your members, clients, patients, and aiming for a 5th to 6th grade reading level, which you can use on Word. There's a way to determine the reading level. All right, we just talked about some red flags. If you have clients or members that you're meeting, that you're managing their care, and they have any of these, you may suspect a limited health literacy. So things like missing appointments, not filling out forms correctly, not taking medications as prescribed. Things that, asking fewer questions, unable to give coherent sequential history. I think the fewer questions is a really important thing, and we'll talk about that. You want to give your clients an opportunity to ask questions. And if a person, if you're telling them the care plan and they're just nodding, and at the end you say, do you have any questions, and say no, that's not a really good way to ensure that they, understood that. So that can be a red flag, and that's what we'll talk about in a few minutes. So using a universal precautions approach is important. I'm not going to ask everyone to come off mute, but I'm sure most of us are familiar with the protocol for bloodborne pathogens in medicine. And remember, when HIV became prevalent, it was important to know that you cannot tell a person has HIV just by looking at them, right? You can't tell it by their education level, their job, anything like that. If there's blood that's spilled or a needle stick, etc., we follow a protocol because we don't know. And so if we assume a universal precaution approach like that for health literacy, it can be very helpful. So just like that, we can't assume what a person's level of health literacy is just by looking at them, right? Or what their education or job is. By taking a universal approach, we just assume everyone has limited health literacy. So it forces us to think about how we communicate and change how we communicate. So we're, always in that mode. And the goals of this are really simplifying communication, confirming comprehension, reducing risks of miscommunication, right? And this will support patients' efforts and make the healthcare system easier to navigate. The more we normalize, the less we stigmatize. Okay, so I'm not going to go through each wheel of this circle, but you can see here, this is kind of what does a health literate organization look like? And it really comes from the top, and it goes all the way down through the organization to the end user, our clients, right? So things like addressing health literacy, making sure the materials are readable, preparing the workforce to have communication tools, et cetera, et cetera. So with that being said, this is our end of our, I'm going to turn it back over to Maya.
Thank you so much. So this is another interactive moment, if that's okay. So does anyone have any experience with a family member or a loved one that had low literacy And how was that loved one or family member impacted by that?
Does anyone want to share? Maya, you can share.
Yeah, I'm sorry. So I definitely have had experience with low health literacy. Here recently, I do like to share that my mom is an aging adult and she has many health issues. So here recently, she was having some issues with her heart and she wasn't really understanding some of the medical jargon that the doctors were saying. One thing that stuck out very specifically and during her appointment that I went to with her, her provider just kept saying tachycardia. So I know what that is, but unfortunately my mom did not know what that is. And she, again, an older adult, so age definitely came into play here. She did not want to stop the doctor and say, hey, what does that mean? So she would just nod, she would just nod after he would explain something. So after the doctor left, she said, I really don't understand. I really don't like this doctor. I don't know if I want to come back to this provider. He doesn't take his time with me. He's not patient. I'm just not understanding. So I did explain to my mom what tachycardia meant. But I did also want to empower her to, to ask questions, if she doesn't understand something. But we'll get into that a little bit later in the training. But I think that's a common thing that sometimes clients or patients, even as a CHW, I've seen that where patients will just nod and, not ask a lot of questions, and then we won't see them for a while. So having that health literacy or that low health literacy does kind of break down the trust between the patient and the provider. So thank you for allowing me to share that.
Yeah, thank you for sharing.
Mhm.
Does anyone else have an experience or perspective like that? Okay, well, we'll continue on
Okay.
and move on to this.
Okay, so we'll talk about the health literacy interventions. So these are evidence-based interventions and strategies that are used to increase health literacy. And it does also help create a more health literate environment. Okay, so the first strategy we'll talk about is clear communication. So greeting the patient warmly when they walk into the office, using the patient's words, showing graphics. We absolutely love to show graphics, making eye contact, slowing down, that's a big one for me, demonstrate how it's done, listen carefully, limit and repeat content, invite patients' participation, use plain non-medical language. So avoiding that medical jargon and medical terminology, be specific and concrete, and encourage the patient to ask questions. Okay, so 7 things to consider when communicating about health. So the first one is trust. Will the person trust that information? Who is the best person to put that information out? So for the CHWs who may be on the call or watching the playback, that is where we shine. Sometimes we have more time. We have the rapport with the patients. So sometimes it is that's our strong suit, helping build that rapport. So the second point is the information. So what information is necessary? And is too much information being communicated? As we know, information overload is definitely a thing. If too much information is shared all at once, I can only speak for myself. My brain kind of goes into autopilot mode and I don't clearly get all the information or what I need. So, and also 3, motivation. How relevant is the information to the person that you're trying to reach? So what is their motivation? I do like to share, I have, as a CHW, I would connect or actively listen to find out what is the person's background. Do they have children or grandchildren that they are excited to be here for, and connect that with what health information we're sharing. So I think we're supposed to split this slide, Dr. Custer. I always do this. So do you want to take the next few points or do you want me to keep going?
No, actually,
Okay,
go
great.
ahead.
Okay. So the environment is the fourth consideration. What conditions are surrounding and affecting the audience? The capacity is the fifth. What is the person's ability to act on the information? Are there barriers? That is a big one. It's difficult to talk to a patient about specific health things if their basic needs aren't being met, and we'll talk about that later in a slide. And perception, what will the audience think about the information? And what will inspire them to act? And then the last point is the response. How will people respond? And how can you keep them engaged? Thank you.
Okay, so we did talk about using plain language. So instead of medical jargon, make sure that you try to always use plain language, right? So here's just a list of some examples. The one thing that I always point out is the word diet. If you ask a patient or a client, what is your diet? They might think you're talking about like Weight Watchers or Atkins or whatever fad diet there is, when actually what you meant is what do you eat every day, right? So just keeping that in mind and understanding that our words may either confuse or not be clear. Okay, so your COVID test is positive. This is an example of what I was just saying. We did a screening fair, and someone had a positive response, and we said your COVID test is positive, and they thought that was a good thing, right? Because positive is a good thing typically. So we ended up changing what we were writing to either you have COVID or you do not have COVID. And that's okay. We adapted, right? We recognized that medical jargon isn't always appropriate. So the first strategy is communication. Clear communication is the key, as Maya will always say. So we're going to move on to our second intervention, which is using effective health education materials. So this is kind of an interactive piece of our presentation. So if you would like to join in and do some evaluation, we'd appreciate it. So just some steps beforehand. In order to be effective, again, like we said before, this is what we recommend. Check your readability, make sure the materials are easy to read and understand. The purpose of the material is clear. No irrelevant information. So, we talk about information overload. We don't want it to have so much information. Common everyday language, of course, like we just said. Material broken up into chunks that make it easier to understand. You can see a flyer with all words all the way down, or you could see a flyer with some, chunks and visuals and whatnot. Materials identify at least one action item to be effective, and the visual aids are used effectively. And of course, be aware of confusing numbers. So using effective materials, we're going to take a look at some. Again, if you want to come off mute, we'd appreciate it. If not, we'll show you what we're talking about. So we're going to start with 3 flyers. These 3 flyers are all, they came out last year, all regarding immunizing school-age children, although children in general. So we have one on the left is from MDHHS, the one on the right is from the CDC, and the one in the middle is one that I love from Authority Health. And, if you look at these 3, they all kind of have similar information. This one says, keep the school year fun going. This one says COVID-19 vaccine. Does anyone have any thoughts on which one of these 3 they think is the most effective? Like if you were a parent with a school-age kid, which one would make you most motivated?
I think I'd prefer the middle one just because it's just straightforward COVID-19 vaccines, the ages, and then it tells me exactly where to go and what number to call and when, and the address. The rest of them are kind of, I don't know. I like the graphics on the left one, but it doesn't really tell me anything. I would then have to go and click on their link to find more information about the COVID vaccine. And then the CDC one is just it's like all text and just, I don't know, from this vantage point anyways, it just looks kind of jumbled.
I agree with Lucas. I think the middle one is more straightforward. It has the phone number. It looks like they schedule, like they are a family center and they are like taking appointments. And the other one just kind of, like I would say the one on the left just kind of talks about just staying up to date with it, but not really like it's not a place really to go to. Just kind of giving that information out there. But yeah, I would go with the middle one too. And there's like less images and graphics, just the little bears at the top. So I would go with the middle one as well.
Yeah. I mean, all parents, right, can probably relate to this. Keep your cubs safe. Any other thoughts? Thank you so much for sharing. Okay. We're going to move on to the next. So this was one that MDHHS put out, and they actually put it out in like a bunch of different languages, which was surprising to me. But how does this message work? Would this message be effective with your clients? So scientists have taken hundreds of steps, and then we talk about research and clinical development, thousands of volunteers, clinical trials, scientists. Would this, in this picture here, would this move any of your clients? Would that motivate them? Do you think this is effective? Anyone? Either way is fine.
I personally don't really think so. I think, especially with the COVID vaccine, just because a big thing with that was people felt like it was rushed. So I think somehow highlighting that decades of research part, followed by months of clinical development, would be more useful if, like, honestly, if they had just like a number of years that like the mRNA technology was in, development for and use for, I think that would have been more helpful. This really doesn't do like anything for me personally.
Thank you for sharing that. And that's kind of what the consensus has been since we started this series is, yeah, as far as effectiveness, this necessarily wouldn't change your client's mind. Okay, the next three I'm going to go through, and these are just examples of clear messaging. So the first one is the Omicron booster. There's always confusion. Anything new, right? This is a new disease, so there is going to be some confusion. But just looking at this flyer, you can see that there's multiple asterisks. And to me, whenever you have multiple asterisks, you start to create not that it's unclear, but the public would see potentially that this is unclear. This is another example. This one I still get plagued calls for this one. Multiple asterisks, you have to read the fine print at the bottom, and people didn't understand this. There was a big gap between employers, and so I'd get a call from my friend saying, my daughter's on day 6, she's still coughing and she's really got a fever. And I said, well, then she's symptomatic, she can't go back to work, but her work wants her back. So this was just, Lucas, please.
And just an example for this one, because I specifically have been like the point of contact at the health department for schools during this entire pandemic, and even for nurses. So who have received, clinical and health training, almost nobody ever looks at these asterisks. And there's so many times where their question is the specific asterisk, but they never looked at it. So yeah, I have a lot of personal feelings about this specific infographic.
It's a visceral response, isn't it, Luke?
Yes, exactly.
Yeah, so yes. Did anyone else have any experience that they would like to share? Confusing messaging. But like I said, COVID's been really tricky. The last one I want to share, and then I'll turn it back over to Maya, is Mega COVID-19 Plan, again, MDHHS. So they have these big points and like a little helpful, visual. What do you think about all the fine print underneath? Could we make this more effective looking or more effective, period?
Yeah, it's very difficult to read. It's very small and it could be overload.
Could be overload. Yes, and what's been said in the past is, these could just be the main points, So we'll go ahead and go on. All right, Maya, I'm turning it over to you.
Thank you so much. So we're gonna go through a few more flyers. So I understand that not everyone can come on mic, but please feel free to answer or respond in the chat as well. So this is a flyer from MDHHS, and it's titled "Why Vaccinate Your Child Against COVID-19." So what are our initial feelings? Well, I can share my initial feelings when I see this flyer. It's a little scary. There's a ton of information here. There's some great bullet points, but there's like a person in a hospital bed, a cute little baby crying, like a sick child. So what are our feelings when we see this flyer? And if we think about our population served for our community health workers, how effective do we think that this flyer would be for our population served? Too much information and too many long paragraphs is the feedback from Andrea in the chat. Yes, I agree. And if we recall some of the things that we've covered earlier in the training, some of these words may be a little bit difficult if we're considering health literacy.
All right, the next slide.
Mhm. Okay, so this flyer is from the CDC, and it's COVID-19 vaccines for children and teens. So this one, while it doesn't have some of those scary pictures, it has a ton of words. So how are we feeling about this flyer? Even worse, yeah. Thank you, Andrea. Any other feedback or any other feelings anyone wants to share about this flyer? Again, I just want us to keep in mind our population served. So if I'm a patient or a parent sitting in a doctor's office or clinic to get my child vaccinated or for a visit, how would I feel about this?
It's too much. I wouldn't even read it.
Exactly. It is a lot. So I do just want to add the two flyers that we looked at are communicating the same information.
Hold on, I'll go back. This flyer and this flyer.
Yes.
Okay.
All right. So moving on. So using health materials, we don't want to assume that the patient can read the materials. When reviewing a handout, especially as a CHW, because just to be honest, the information that we have, the tools that we have in our arsenal are the tools that we have. And sometimes the tools that we have are these flyers that have a lot of information. So when reviewing the handouts with patients, you can circle, it is helpful to circle and highlight the information that's important and personalize the material by adding their name and also any medications. Using Teachback, we'll get more into what Teachback is later in the training and emphasize the importance of keeping the materials so that they can refer to it when the patient does their follow-ups. And make sure the person has internet access when we're recommending digital materials. So I know sometimes it's really easy to say, oh, just check the CDC's websites for any changes or updates in COVID-19. But we have to make sure that we're being sensitive and making sure that the patient has access to those digital resources. Thank you so much for that. And obtains the patient's feedback on the materials. So that is helpful with making materials in the future and also understanding what's effective for our patients.
Okay, so our third strategy, like Maya just mentioned, is teach back. And so why are we even doing any of this, right? So studies have shown 40 to 80% of medical information is forgotten, and what's remembered is half of it's incorrect. So these are why we're improving our communication tools, right? And teach back is a great method. We have a small audience. Has anyone learned about teach back? You can put it in the chat if you'd like. If not, this will be your first exposure, and that's exciting. Okay, so teach back is a method of just a way of checking understanding by asking the client or family member to explain back in their own words what they need to do. So we're not pimping patients, we're not quizzing them. This is not a test, right? But this is just a way, a manner of communicating so that we can make sure that they understand. Why is it important? It does improve patient understanding, which can lead to decreased callbacks, canceled appointments, increased patient satisfaction, and increased compliance with the treatment plan. So some of the things, just like communication, some of the things that work great for teach back, using that caring tone of voice and attitude, displaying comfortable body language, making appropriate eye contact, using that plain language like we talked about in effective materials. Here's a quick overview. So, you want to chunk and teach information. So if a patient has, asthma, diabetes, and hypertension, you would want to do each one of those separately. You don't want to try to overload the patient at the end with a discharge, a summary of, all the different things. And then you just ask the patient to teach back in their own words. If they're able to, then you can move on to the next thing. If not, then you try to, re-explain it in a slightly different way. And then ask them to teach back again. So teach back, motivational interviewing, two things that we're going to review today that I would encourage everyone to follow up and get more information on. Teach back is a thing that you learn and have to practice. And there's a lot of great examples by video on YouTube if you are interested in looking more. So what we'll do real quick is Maya and I are going to do a reenactment of a teach back example. The next few slides are going to be representative of a handout that I would, just imagine we're looking at it together. Okay, Mrs. Campbell, as you know, your COPD and diabetes put you at a higher risk for developing severe COPD. I'm going to prescribe you with the antiviral medication pill called Paxlovid. So here's what a dose of Paxlovid looks like. You can see there's 2 pink pills and one pink pill in each packet. Here's the names of them if you're interested. So you need to take all 3 pills 2 times a day for 5 days. Here's some additional information about Paxlovid. I've highlighted the most important things, such as taking the pills whole. And here is a list of medications that you should avoid if you're taking Paxlovid. Do you recognize any of these?
Yes, I do. I actually take St. John's wort daily.
Okay, so while you're taking the Paxlovid, we'll make sure that you don't take the St. John wort. Okay. And here's some side effects. The most important thing to look for is liver problem. So if you start to get itchy, your skin turns yellow, your eyes turn yellow, or your urine turns dark, we need to know right away. And here's some other side effects. I've circled them. They're the most common and they will usually resolve within 48 hours. All right, I'd like to make sure I explained everything clearly today. So can you please tell me how you're going to take Paxlovid and what you're going to look for?
Okay, yeah. So each pill packet has 3 pills. I need to take 1 packet 2 times a day for 5 days and avoid other medications like my St. John's wort. But I can't remember what side effects to look out for again.
Okay, just remember liver damage is the big thing.
Okay, yeah, that's right. So if I notice any changes with my eyes or skin, or if my urine gets dark, I'll be sure to give you a call.
Sounds good. So as you can see, that was just a brief teach back example. I provided information using plain language, etc. Does anyone have any questions about teach back? Okay. So we'll move on to our 4th. Now, this is not a real, I shouldn't say this is not a real, this is not a necessarily really evidence-based intervention, but this is a project that I did with Authority Health that I wanted to quickly go through. So we did a project called Wash and Learn, and we were at a laundromat at 7 Mile and Van Dyke, and we would go every weekend, and the residents at Authority Health were providing health education. And our goal was to improve health literacy. And unfortunately, the pandemic interrupted that project. So we switched gears and we turned to a Small Steps to Health, which was planned for a laundromat near Narden Park, where Hope Academy is. And this is really the point of bringing this up. Small Steps to Health was all about small step behavior change. And for the two of you that are left with us, you know, when we have a patient clinic in the patient, when we have a patient in the clinic, and let's say they have high blood pressure, we have a tendency to say, okay, we need you to walk 150 minutes a week, or we need you to walk an hour a day, or 60, you know, really big overarching, we need you to increase water in your diet. You know, we need you to decrease salt. Those are all really broad goals. And it's hard for patients to just, you know, start implementing all these broad things. So we talk about small step, setting small goals. So rather than saying, you know, go out and exercise every day for 30 to 60 minutes, we might say, okay, what are some things you can do while you're in your house? You know, we've heard grandmas that watch YouTube with their grandchildren, they dance. You know, rather than saying just increase your water, you might say, could you try drinking a glass of water in the morning before your coffee? These are just, you know, we'll talk about motivational interviewing in just a few minutes, but motivational interviewing is the tool to elicit, you know, what the patient's preferences are, what they are able to do. And, you know, then you create your goals based on that. So with that said, we'll move on to culture and language.
Yes, thank you so much. So that culture and language is our fifth health strategy or considering health, language, and culture. So as we know, Wayne County, fortunately, is a beautiful melting pot of different language and cultural beliefs. So because it is a melting pot, it is important to understand the population served. We'll begin with a review of CLAS, or CLAS. So CLAS standards are culturally and linguistically appropriate services, and CLAS is a framework to deliver healthcare services in a being respectful and responsive to the patient's cultural beliefs, preferences, and communications. And CLAS does promote health equity and reduces disparities. Okay. So CLAS themes is a principal standard of governance and leadership for the workforce, communication and language, and engagement and continuous improvement and accountability. So some strategies that we'll discuss to implementing CLAS, the language related strategies, access to language preferences and language assistance needs, using acceptable language assistance services. We'll talk about that a little bit more in depth in another slide. Plan for interpreter services in advance. This again is another key point for CHWs to shine. During my time working in a clinic as a CHW, one really helpful thing that I would do, I would always look ahead at the schedules for the week and I would plan accordingly. So if we had patients that did need interpreter services, I would make sure that that was set up prior to their appointment. Provide written materials in the patient's preferred language is another strategy as well. So some culturally related strategies, respectfully ask the patients about their health beliefs and customs, avoid stereotyping based on religious or cultural background, and acknowledge and address any implicit biases. So some language translation services do's and don'ts. So we do want to use bilingual clinicians and staff members whose proficiency has been confirmed. We want to also use staff who are trained as interpreters or on-site trained medical interpreters, or the use of phone or video medical services like the interpreter lines. So we do not want to use staff that have not been trained or confirmed their proficiency as medical interpreters. This is a big one as well. Patients do frequently, from my experience as a CHW, many patients who did have language barriers would bring family members or friends in to interpret. We do not want to do that. And the reason behind that, the why, it does pose an issue for the patient's privacy. So we want to be respectful of that. And minors should never be used. That is another very common thing that I saw as a CHW. Patients would bring their minor children because maybe they spoke the language better, but we don't want to do that. Thank you.
Okay, University of Michigan has this thing called the Care Guides. The link is at the bottom of the slide. I recommend looking through this if you haven't already. They have taken a lot of time and really intentional in creating 5th to 6th grade reading level materials for almost every condition and translated into, several different languages. So some of it they've created, some of it they've procured, but they're all available and free, and it's a great resource. For COVID, the MDHHS did put out a series of flyers that were in different languages. Those are also available if you're still interested. Okay, so that's that. We're going to move gears and talk about cultural competence. So cultural competence, we have to be competent when we're healthcare providers, right? Religion, culture, beliefs, we know this. Ethnic customs can influence how people understand health, how you take care of it, how you make decisions, etc. And cultural competence relies on the principles that we've really been discussing this whole time: trust, respect for diversity, equity, fairness, social justice. And we become better providers if we consider culture and language, right? So it's important to engage patients, make treatment plans that are consistent with their values. Okay, so how culture can impact health engagement. And these are just some examples. So health beliefs. In some cultures, people believe talking about a disease could create that outcome to occur. Health customs, family members may play a large role in the decision-making, elders, etc. Ethnic customs, roles of men and women in society may determine who makes decisions. Religious beliefs can impact health behavior. So religious, there may affect how someone uses the healthcare system or the willingness to accept certain treatments. Dietary customs, very important to consider when working with different cultures. We may recommend a diet plan or a meal plan. And if the client's not able to, doesn't have the wherewithal or knowledge to cook that kind of food, we have to consider that we need culturally responsive food plans. Interpersonal customs, eye contact, physical touch. Some of these things are expected in certain cultures, some of these are not, and they could be seen as inappropriate or offensive. So it's really important to know the population that you serve. Addressing implicit bias, I'm sure both of you have heard this and are doing that. We all have unconscious, sometimes conscious bias. We're all brought up and we have different, upbringings. We have different cultures, like we just talked about. We have different beliefs. Our worldview is shaped by what we experience in our early lives and throughout our lives. So because of that, we need to reflect, right? We need to make sure that these things don't impact our level of empathy or the way that we communicate. All right, so this slide, this whole entire section here, each one of these slides could be a whole, series themselves. So I encourage you to look further into information if you are interested in anything we present. Trauma-informed service. If neither of you have, Andrea, have you ever heard of this, or Lucas?
I started it. Didn't finish though. It was a little too science and technical for me.
No, I haven't heard of it.
Yeah, it's an interesting that you said that, Lucas, because I've heard that before. So, we recommend The Body Keeps the Score to everyone who can read it. It's important to understand how trauma can impact the mind and the body. So on that same note, it can be really packed. So toxic stress, have you heard that term?
Yes.
Okay. Andrew, you don't have to. So we are aware now of how the trauma and toxic stress can impact the body and adverse childhood experiences, right? But trauma can impact you throughout your life. And so we bring this into it. Maya, don't leave me. Because cultural competence and trauma-informed service are very similar. I threw in a Maslow's hierarchy of needs slide in here because I think it's important that we consider always, the basic needs when we're working with a client. Maya, I don't know if you wanted to share some perspective from a clinical standpoint.
Absolutely. So when we think about our work as community health workers, I always go reflect back to my time during the pandemic, where we were seeing an increase of patients having like issues with mental health. But we were also seeing, because we were in quarantine and people were unfortunately losing their jobs, we were seeing people going through financial struggles as well. So as a community health worker, like I wanted to push the mental health and the support groups and the counseling, but it's difficult to talk to a patient or a client about mental health when they don't have food in their home or they're going through an eviction. So it's important when we're working. I know that we are all probably very aware of this or seen this hierarchy of needs, but it's important that we keep this in our tool belt because it is important, because it is difficult to talk to someone about things higher up on the pyramid when their basic needs are not getting met.
Thank you, Maya.
Mhm.
This image is the pair of ACEs. This comes from Dr. Dietz at George Washington University. And really, this is just showing we understand adverse childhood experiences and the effect of stress on development. But in order to, make an impact here, we need to consider our adverse community environments. So, this is just a slide to show again that there's so much systemic inequity that we need to solve and work on to bring everyone into a healthy environment, healthy community, healthy families, et cetera, et cetera, et cetera. All right, so I do a trauma-informed service lecture, and these questions are some of the questions. The audience for this was professional students, so like nursing, medical, et cetera. And so I challenge these to everyone to ask yourself when you're working with your clients, have you considered the trauma this person has experienced? You could very easily put culture in, right? Have you considered the culture of this person? Are you creating a safe place to share? Do you have any unconscious or conscious bias to consider? And can you even be unbiased about certain things? These are things that you need to think about. How does your background or history, et cetera, impact your ability to serve the person? Are your actions making others uncomfortable? Are the words you're using respectful and culturally appropriate? And are you listening, or are you just talking or listening to talk? Right. So creating a trauma-informed, culturally competent space, we have to consider all of these things. So on that note, does anyone have any questions about what we just reviewed or any comments?
Nope.
Okay. Do you guys want to take like a 3-minute break?
Yeah, that sounds good.
Okay, let's do, because it's 9:50. We'll probably honestly be complete before we anticipate to be complete. So let's just do come back at 10:02. Okay, let me pause the recording. Okay, so welcome back, everyone. We're going to go through the second part of this session. Strategies to overcome vaccine hesitancy. So we're going to move on to 2 methods specific to COVID-19. Well, you can use them for anything, but. Okay, so what is vaccine hesitancy? The World Health Organization defines it as a delay in acceptance or refusal despite access. We know that we have available vaccine here. This is one of the top threats to global health, and there are few effective strategies. So we need to work on this. The causes are just the things that we've really been discussing throughout the session. Systemic inequity, inequality, lack of effective public health messaging, a history of unethical research involving minority groups. We are very well aware of, in the history of our country and using minority groups to do testing on, and that's why we have so many research protocols now, which is good. Social disadvantages, like we talked about, access to education, access to quality care, information. The growing spread of misinformation, disinformation, conspiracy, barriers to access. So these are some of the causes that we are aware of. You guys both know this most likely, but just a quick review of the vaccines. The primary series was a monovalent. It covered the original strain. Depending on the type, it was 1 to 3 doses. The booster, which is out now, is a bivalent, so it covers the original strain and the Omicron BA4 and 5. So again, this is 1 dose is recommended for everyone age 6 months and older. However, now, the CDC, this will continually, the FDA and the CDC will continually evaluate the appropriateness for boosters. And they've just recently, I don't know if they've made it a recommendation yet or not, but they're leaning towards boosting adults over 65. So it's important to keep, your finger on the pulse of what's going on with COVID specifically. So this is a great, COVID-19 vaccination field guide, some strategies that you can implement. The 2 that we're going to discuss today are motivational interviewing and combating misinformation. So I'll turn it over to Maya.
Okay, so what is motivational interviewing? So it's the guiding style of communication that balances good listening and giving advice. So it's designed to increase the patient's motivation and likelihood of behavioral uptake. It's based on respectful and curious ways of being with being with people, and facilitates a natural process of change while respecting the patient's autonomy. Okay, so spirit of motivational interviewing. I love this table, but we don't have to go through each point step by step or in depth, but the spirit of motivational interviewing is collaboration. So a partnership between the patient and the provider. The patient's activities and the patient's own motivation is taken into consideration, and honoring the patient's autonomy, which is the provider acknowledging the patient's rights and freedoms. So that's the spirit of motivational interviewing. But the old or the authoritative way of being with the patient is based in confrontation, and the provider knowing what's best for the patient. And education, the patient is presumed to have a lack of insight and the authority that the provider has over the patient. I do just like to say in brief, the patients or our clients, our population served, they are the experts in their situations. However, the provider may be the expert on the medical side, but again, the patient or the client, they are the experts in their situation. Yes, thank you. So this slide talks about OARS, OARS. So what this is based in open-ended questions. So these questions cannot be answered with yes or no. I'm pretty sure we all are aware of open-ended questions. So they kind of force the patient or the client to respond conversationally. So affirmations. So be sincere. So an example of that would be, it takes a lot of strength to, so they can be used, this affirmations can be used to help point out any discrepancies that you may have in any information that the patient is communicating. And reflections, mirror what the patient is saying. I know earlier in a slide, we discussed using the patient's words, and that reflecting does help build rapport as well. And summarize. So going back through and letting the client know that you're listening and repeating what they said. So this also helps clear up any discrepancies. So thank you.
And please, the OARS technique is a very common technique to use for motivational interviewing. Please follow up with more information.
Yes.
Some examples on YouTube.
So motivational interviewing strategy to discuss with COVID. Again, you want to start with open-ended questions. A soft start to a controversial topic is always good. Acknowledge the patient's concerns without being judgmental, and showing empathy does reduce the perception that you approve or disapprove. Avoid criticizing the patient's information source. For many, their information source could definitely be a respected elder, a church leader. So you don't want to criticize. That is a good way of breaking down the rapport with the patient. So we want to avoid that. And we just want to provide high quality factual information to combat any misinformation that they may have. So bullet point 4, show awareness of your status as a messenger. This is especially important with communities of color, and link vaccine acceptance to the patient's hopes and goals. I always think about a patient who was super excited to get back to her normal life, to be with her grandchildren. So we link that to the vaccine, hey, I know it's really important that you're with your grandchildren. Consider, the pros about taking the vaccine and how important it is to stay healthy for your grandkids. So thank you for that. Okay.
So we're going to do a reenactment using motivational interviewing. And so I'll be the healthcare provider and Maya will be the client, the mother. And what we'll do is we'll do the first reenactment will be the traditional approach or style to medicine. And then the second will be a motivational interviewing approach. Okay, so here's the traditional approach. Ms. Campbell, it's important to immunize your child. If not, you're putting him in danger. Do you know there are still cases of measles out there? This disease could be very dangerous. And what about meningitis? It could be fatal, You should update your child's vaccine schedule as he's already late. We should do that now.
Okay, yeah, but I don't see the urgency, and autism is way worse than measles. There are more problems and solutions with this vaccine. Moreover, it's really unbelievable to give so many vaccines all at once.
Studies have demonstrated there is no link between autism and the measles. The vaccine is safe, I assure you. You should be aware of the information you find on the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should update his vaccines now.
Yeah, well, I heard something else, and not just on the internet. I do read, So the vaccines are not mandatory, so I can do whatever I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of disease is much higher than the risk of the vaccines. If I'm taking this time to share this information, it's really important.
Yeah, that's easy for you to say. Everything is so quick. But what if he gets autism? I'm worried about the risk of the vaccines, but you don't seem to be worried about the health of my child.
Of course I am. And I'm worried that he could get diseases that could be prevented by vaccine.
Yeah, I don't think that we're understanding each other. So let's just talk about this at another time.
Okay, so in this example, I adopted the role of the expert, used a directive intervention based on argumentation and writing reflex. So basically, I'm right, you're wrong, and that led to an opposition. So now let's do an example where we use motivational interviewing approach. Excuse me. So Ms. Campbell, what do you think about the advantages of vaccination?
Well, I know that vaccines do protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm worried about the measles vaccine specifically as it could cause autism. For other vaccines, I don't have as many doubts, but I'm still hesitating.
As you said, vaccines have reduced diseases in such an important way that they are now much less frequent. It's why you vaccinated your child when he was a baby, right? If I understand you correctly, with the exception of measles, other vaccines seem safe to you?
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. I read a lot of books and articles, and lots of people are worried about the link between measles and autism.
So you find it's important to protect your child against diseases when the vaccines are safe, but you're worried about what you've heard regarding autism and measles. I see you've done a lot of research on this subject. If you would like, I could give you some additional information for this study on autism and measles.
Sure, that would be great. I want to know exactly what's going on.
In fact, you're right. One study had hypothesized a link between vaccine and autism, but this study was fake and the author lost his medical license. More than 500 additional studies around the world have demonstrated that there's no link between the vaccine and autism. The frequency of autism is the same in a group of vaccinated children as in a group of unvaccinated children. What do you think?
Well, so I'm not so crazy to be worried about that.
Of course not. You're totally right.
Okay, well, thank you for taking the time to understand my concerns, and I think it's a little bit more clear now.
Okay, so in the second example, motivational interviewing allowed the mother in a non-judgmental way to express her concerns. This used the elicit, share, elicit method, but basically asking open question, reflecting, right, summarizing. And that allowed me to give her solicited information that was acceptable. So she's more likely to accept the vaccine. Do either of you have any questions about traditional approach versus motivational interviewing?
No, I think those were helpful examples.
Okay. And like I said, if you want to learn more, please go to YouTube or there's lots and lots of information on this. Okay, so our last strategy we're going to discuss is combating misinformation, disinformation. Do either of you know the difference between mis and disinformation?
Disinformation is like if it's being spread like on purpose, and then misinformation is just like there might not be like a nefarious reason behind it, but it's just incorrect information.
Right. I commonly will, think of this in patient safety terms, right? Like a mistake or an error versus a violation. So misinformation, it's incorrect, but the person spreading it isn't necessarily aware that they're spreading it, that it's misinformation. Disinformation is purposeful. So let's go ahead and get into this. So we're going to talk about the role of social media and the importance of trusted messengers. And this is really the only thing about social media to discuss is that it's huge, right? So we have in 2022, all these different ways of getting information. It's funny because when we were little, we had a newspaper, we went to the library, right? Well, maybe not everyone, but now we can see there's a lot of different places. So we have to keep that in mind when we are talking to our patients. Dissemination of factual and easy to understand information combats mis and disinformation. So like Maya was talking about earlier, it's better to provide just factual information than to try to argue against misinformation or to judge. And really use your credible sources to demonstrate facts. We have come across several times while we're doing these sessions where people say, well, what do you do when the person doesn't believe the credible source is credible? And so that's something to think about. And I don't think we've come up with a solution quite yet for that. But it's something to think about. Our trusted messengers, celebrity-based, faith-based neighborhood champions. We've seen them in all the Detroit commercials, I feel like, for the COVID vaccine, encouraging people to get vaccinated. It really does make a difference if it's from a trusted messenger. This is a little bit dated now. I think I pulled this in November or am I still here? Can you still, okay. I just got a thing saying my internet was.
Yeah, you froze for a second, but.
Okay, thanks. Lucas, you're an epidemiologist, aren't you?
Yes.
Okay, so I'm not going to talk to you about this. But honestly, this is the information, right? So we can present this, we can say, okay, this is what's happening. If you are not vaccinated, you're more likely to be hospitalized and you're still more likely to, die from COVID-19. And I think, Andrea, if you haven't seen this, this is, the black lines, the vaccine or the deaths unvaccinated. And then we have our vaccinated death rate. And then the Omicron's like almost close to zero. So that's all I'm going to do about data because Lucas is on the phone. I'm just kidding. Okay. Oh, okay. So we're going to open this up. Maya?
Yes. So who could share a situation where someone either personal situation or while working with a patient or client where they refused to get the vaccine due to mis or disinformation? How did you react and was it effective? Andrea or Lucas, do you have something to share or a specific situation to share?
So I think if you go back to that previous slide, what a lot of people will say is, well, hospitals are getting paid extra money to classify, these people as COVID deaths when they're not COVID deaths. And it's just like, even just sharing data has just become, especially like around COVID specifically, it's just become so like polarized when it doesn't need to be. And so, I mean, literally everything that any data that I pull, like the definitions have to be clearly listed and stated, and just everything has to be out there for that. But in terms of the vaccine, specifically, because I've had a lot, just working in this since the beginning, I have a lot of like friends and family that come to me just asking me, their honest opinion. And I think the way that I typically take it is, we had talked about it earlier, like what type of conditions they may have that put them at higher risk for, severe outcomes from COVID-19. And kind of go about it more that way. And I don't say like, yes or no, you should get it. Obviously, I think they should get it. But I kind of will phrase it in terms of outcomes that may be with the specific risk factors that they have. And, kind of leave it to them to make that decision.
Yeah, thank you for sharing. That's interesting. So like if they were certain conditions, you can say, okay, well, that would, this is the outcome.
Exactly.
We haven't heard that yet. So that's interesting.
Yeah, I typically don't even start with data anymore, just because it's so fraught and with tension right now. But I like, for my mom, trying to convince, and she's one, I think that you see this a lot, she got her primary series, she got her, first additional booster. And then when it came time to get this newest bivalent booster, it's kind of been, she's giving me the, well, I'm all, vaccinated out this year. Because she got her flu shot, but was then gonna wait to get the bivalent booster. So I've taken it to, you're 65 and over, have a heart condition, looking at your, I don't say this, but like, you're a little bit overweight. So these are all serious risk factors for severe COVID-19 and outcomes. So, you need to think about that in terms of, weighing the benefits and the risks for the vaccine. And she did eventually get it, but it was just kind of this, well, I'm all vaxxed out for this year, or, that kind of thing.
Yeah.
But I think when highlighting those risk factors, just because she does know that I work with this on a daily basis, and, we're seeing the deaths that are coming in each week. And it's almost exclusively now people 65 and over that have some sort of, comorbidity.
Mhm.
Okay,
Yeah.
thank you. And I'm sorry, Andrea, did you have something that you wanted to share?
I think we do see like a lot of different things here at CHAS, like in the clinic. But I know like there was like a lot of disinformation, that was purposely out there, like back when people were like conspiracy theorists and they thought like the what was it, like there was like a microchip in the vaccines.
Mm.
So it's good to just like tell people like the facts and just like let them know like you're not getting microchipped, and just let them, just let them know that it doesn't, but also, give them their time. Sometimes people just need a little bit time to really think about it. But just like giving them fact sheets or just information that just has accurate information. And I think that helps them. Then they end up like coming back or like just giving us a call, or they'll say like, oh, like, after we say like, no, it doesn't have a microchip, they do go ahead and like schedule with us. So,
Okay.
it's just good to like shut things down if you can right then and there, because, a lot of things were a little crazy, peak pandemic. A lot of people were spreading false information, and now that we have like TikTok and everything, there's just like always conspiracies and like cancel culture and everything. So yeah, just I think it's good to like just shut things down when you can.
When you can, absolutely.
Mhm.
You're right, Andrea, and thank you so much for sharing that.
Mhm.
Because like we talked about earlier in the training, we want to respect the patient's decisions and their autonomy. But it is, our responsibility to give that factual information. So thank you so much for that. So Dr. Custer, I'll turn it back over to you.
Okay. Are we doing the case, Maya?
We can if you'd like. Oh, I mean, we definitely have, I believe we have time, right?
We have time. Okay, we'll do a quick case. What we'll do, it's just a short script and then we'll ask you a few questions and then we'll summarize. So let's talk about Eliza. Eliza is a 77-year-old woman. She's at the office and has been diagnosed with long haul COVID. No, that's not the real diagnosis term, but she had a rapid heart rate, shortness of breath, and fatigue since she was hospitalized with COVID-19. She's sitting in the doctor's office listening to instructions and going over the next 3 months worth of treatment. The doctor assumes she knows what he's talking about because she doesn't ask questions and tells her what she needs to do. What the doctor doesn't know, because she's kept it a secret for as long as she can remember, is Eliza does not know how to read because she dropped out of school when she was 8 to help her family farm and never went back to learn. She has little medical background and barely knows anything about heart disease. He gives her pamphlets and written instructions that tell her everything she needs to know, but doesn't tell her what they say. He says to let him know if she has any questions, and she responds with, "Okay, I will." Unfortunately, she can't read the material and is too embarrassed to admit she cannot read the information, which will lead to problems in continuing her health plan properly. So this is what we've kind of discussed throughout the session today. So we'll just, quickly talk through any red flag behaviors that either of you recognized. Some of the things we talked about.
I think just her not, engaging or asking questions or anything like that as a provider would be probably the biggest red flag for me, just going through all the instructions. I think I would stop and ask, try to do the teach back and ask like open-ended questions about her understanding of it.
Andrea?
Yeah, I agree. And I think like the materials as well, maybe just giving, I mean, if she can't understand the materials, just like letting her know, like, here's my phone number, if you do have any questions, or here's my direct extension. But yeah, no, it's good to definitely get some clarity while you're there, and maybe like some easier instructions to understand.
Yeah. So how does her limited health literacy impact her COVID? What could the provider organization have done to be more health literate? Any thoughts on this? So we know, right? Oh, go ahead, Lucas.
I was just going to say, I think asking the open-ended questions and providing teach back for her, as well as asking about if she has like any type of support system that this information can also be relayed to.
And that's a whole nother situation, but that's an important point. As we adopt more and more technology, I was just thinking sharing information, beyond the clinical visit is something we're working on. Anyway. Okay. Back to Maya to sum it up.
Okay, so some of the key takeaways. So low health literacy is associated with lower knowledge, poor medication adherence, increased use of ERs as primary care, and increased mortality rates, which all these things do affect the quality of life. It is important to use universal precautions as we discussed. So just like we do with our other universal precautions, we would just want to assume that everyone has low health literacy. So improving individual and community health literacy levels can reduce the vaccine hesitancy and increase COVID-19 vaccination rates. Okay, so a final review. So the recommended grade level for all written materials is 5th and 6th grade. Health literacy strategies that can be used to increase the patient's understanding about their conditions, empower them to take an active role in their healthcare. If we remind ourselves, we talked about clear communication, teach back, using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation.
All right, thank you, Maya. If you need to get a hold of either of us for any follow-up, here are our, and we'll send the slides out after this. There is an additional training the CDC has that can be helpful. It's a health literacy for public health professionals. I like it. So you can share that. And then at the end of the slides, there's resources that we went through. The AHRQ toolkit is really helpful. So at this time, we're going to ask that, if you have, thank you, Maya. I'm like, there was something in the chat. If you have a phone, you can scan the QR code or use the link in the chat box, or if you're joining us online, the link is below. We would really appreciate your feedback. So if you are interested in obtaining a certificate from Wayne County Community College and some CEUs, you can go ahead and do the post-evaluation, make sure you rate the presentation, and then there's an opportunity to give some information. Wayne County Community College does require your name, address, etc., so that they can register you as a continued education student for the certificate. Any questions about that or any comments before we go ahead and end our session today?
No, not for me.
No questions. I thought this was a great training though. Thank you both.
Me too. Thank you so much for the information.
You're welcome.
Yes,
Go ahead, Maya.
take care.
Thank you.
All
Bye.
right.
Bye-bye.
Do you have access to the link?
Yes.
Okay, I'm going to stop.